Hello.
Hey, good
How
to
are
see
you?
you. I'm good. How are you doing?
Good, good. Let me change the speaker here. All right, turn it up. Trying to get this Zoom change some of its settings. So getting people on the meeting is a little more challenging than it used to be.
Oh, okay. Okay. Is this the first meeting in a while, or have you
No,
been
we've been
doing?
doing them. It's just
Okay.
that now I have to admit everyone into a room.
Oh, you have like a waiting room situation.
Yeah, Zoom changed it so the waiting room became mandatory. So it's a bit of a pain because then it has to pop them up on a screen and I have to find them.
Okay.
So it's not quite as automatic. But the beauty of it is you get to see Tony, and whenever you get to see Tony, that's an honor for everyone.
Yeah,
Oh, he went away. Such a
I'm
beautiful
right here.
man.
I'm still here. How we doing?
Good, good. He's
I'm
going.
gonna try not to huff and puff too much in your guys' ears because I like literally just finished a run and it's actually really hot in Chicago.
Nice. Eric doesn't look hot. I mean, not that's not an objective thing. I mean, look fine. Not warm. Do you think everyone is in the meeting right now? 1, 2, 3, 4, 5. Eric's frozen as usual. All right, Kara. I saw the runner you sent over. I put it in one file. Let's see if I can share my screen.
Oh yeah, I can share mine too, but I didn't know if you wanted them one video per view or.
It was fine. I had a second, so I put it all into one thing. So anterior is the one you get sometimes least from. I can look at foot strike and then I'll look at the knee just to see if your knee spin medial.
Mm-hmm.
How fast. So the more obvious one is right knee, the internal rotation moment greater on the right than the left. Again, Kara sent this one over. I don't know anything about it.
Yeah, do you want to know anything about it before we analyze it, or do you want to?
Now, let's look at it. Give our thoughts. You see what you kind of want to do. She reaches out and then the hip starts to extend at about 80%. That's kind of corresponding with what they call the glute activation as well. So end range extension, the hip starts to move back into end range flexion, starts to move back into extension before heel strike.
I thought it looked like on the right side she had a much more significant heel strike and dorsiflexion angle on initial contact further out in front of her compared to the left. The left, she actually did start to extend prior to initial contact, and that was more, her initial contact on the left was more of the posterior 2/3 of her foot compared to the right being like right on the heel.
Yeah. That's what it looked like. It looked like initially, when I looked at it briefly, the reach did look different. You feel like she's drawing backward, landing more midfoot on the left versus the right.
Mm-hmm.
There, I don't notice it as much.
Something's going on with her pelvis other than her right hip drops more, but I think she's not extending. I'd have to look at it again, but there's it's getting really chopped up now. I don't know if it is for everybody else, but
yeah, it's probably because I was playing with I was moving it too fast. So there's your flight phase again, just after toe off on the left side. Oh, I'll try and take it back a frame. That's about as close as I can get the toe off there. It should be one more frame.
She's not extending on the right. Is that what we're saying?
This would be her left side. So we'd probably be looking at the left hip right now. And again, you look at her body angle, not there now. I think I'm missing the next frame, which would be her full extension frame, which would be toe off. I'm gonna try and slide it forward to it. Yeah, kind of lose it. So like from there, I'd say her hip extension is less, but if we go to the next frame, she may have better hip extension. Through that, because that is her left hip I'm seeing, right? Yeah.
No, that's like her right.
That's her right hip.
That's her right hip.
Yeah, okay, I see, I had the wrong hip. So now I have her, that's her, now we're looking at her left hip because the right shoulder's forward, or left shoulder's forward. That's not bad as far as extension, which you'll see. Flight phase, body angle. That portions of it's within spec. And go to the other side. That looks a little bit better as far as you see the right. I think on this side, this being her right side, looks like it's extended more at this phase than the left side. Is that what you saw, Kara? Or no?
Not as much. I'd have to, let me go back because I believe her left arm had a larger abduction and compensatory swing.
Mm-hmm. I would expect that because I think her internal rotation moment on the right side is greater. And Eric, or if anyone else wants to look at a particular view, either moving or non-moving, let me know.
I'm going to try to take some screenshots and send them to you, Dave, of like her most extended position.
There's toe off on the right. So that'd be a good one. I'm going to switch to the other side. Let's see if I can get a frame of toe off.
I just tried to send you some screenshots too, if that. This makes it look like her. Did you get those, Dave?
Mm-hmm. Yeah, there's one image came over. Let's just try to pull up an image now.
Yeah, I sent both at toe off as best I could. It looks like, to me, it seems like her left hip is extending a little bit more and she gets a little bit more like power out of her left calf, unless I just got a better, you know, really seriously toe off view. Snapshot.
Yeah, it could be that you have a better angle of that. But what I would almost expect that if I'm thinking that she is rotating more on the right hip, as she goes into the landing, that she's going to leak energy faster. So if she's
rotating where?
Like when she lands on her left leg, I think she gets more of an internal or more rapid internal rotation and collapsing moment on the right leg. Which would, again, she's gonna leak energy when she does that. She's not gonna transfer load as cleanly because she's going in and out of rotation versus trying to kind of, again, moving in more of a sagittal plane. The whole lower leg has a more of a transverse plane rotation going to it. So you can see a little bit in the front that the knee goes forward. You can definitely see it in the posterior. It's not, the rotation isn't as obvious in the laterals. And I can go back to that if I can find it. Could you see the image I pulled up, or no? You're still seeing my other screen share. So let me go to the posterior. Sorry, make everyone motion sick. So look at her body. If you see that body angle there in mid stance, you can almost get a sense of, look at that the right leg. The femur is internally rotated at this point. Knees more medial, foot comes out. You see that angle?
Mm-hmm.
I'm gonna bring it out here. Now, me going slow probably screws it up a bit, so I'm gonna let it play because you have it in a slow speed. So she goes and lands. The lower leg kind of follows that foot as she rolls medially through the foot. The left leg, I think the hip drops a bit more, but she doesn't quite get the rotational moment in the right hip. I'm sorry, in the left hip. Not that there isn't one, but I think it's less significant. And that allows her to transfer energy probably through the left leg more efficiently than the right leg. It's her right leg.
Did you say you thought she had more toe out on the right?
No.
You said something about her right toes, but I don't remember what.
No. Oh, how she rolls her weight. So she watches that heel strike. See, the weight rolls medial. It doesn't both feet, but it does she control the hip as she lands? Or does the hip and everything, the whole leg follow that into rotation? So if I can hit play here, if she lands, I think she gets a rapid rotation moment on the right that she doesn't get on the left.
It's like as soon as she lands.
Yeah. So oftentimes you'll look and see, okay, is the femur following the foot, or is the femur happen kind of on its own? So sometimes if it happens in that load-bearing phase, is it following the foot starts to invert, and she should be rolling from lateral foot across the metatarsals, and that should happen cleanly as her center mass goes forward. If she's rapidly going in and that transfer of load is falling medial fast, then the hip can follow it, or the hip can engage and counter and control and kind of keep a linear line. I think it's what you see on her right leg. Is you won't see as much of that rotary moment, but you will get maybe a little sharper hip drop moment. And it could be the same. Hip drop could be relatively the same. But I think there's a larger rotational component on the right side than the left.
Of her femur, right after she lands? Yeah.
Yes. And even the whip might be a little bit stronger. So that whip on the back end might be a bit stronger. Now, whip is coming normal. But, if she's moving rapidly in internal rotation and then she has to kind of come out of it as she's kind of swinging her foot through, it has to go into external rotation. You almost just see a little extra whip in there. And sometimes it matters too, if she's internally rotating more rapidly, she may not be storing as much energy, gastrocsoleus, in the release. because she's going into more of a rotary moment versus my foot's going to hit the ground. My Achilles is going to store the foot, and the ankle can just give a little bit. And so you're not storing energy for transfer. That's a very common strategy where you just lop in jogging, where you just lop one leg out in front of the other. And, the serial elastic elements absorb some, the joints absorb more. It kind of gets a blended approach. Thoughts, Eric?
Yeah, I mean, based on the hip extension that she was getting on the right, I wouldn't suspect it's the femur doing most of the work. I would suspect it's being driven by the foot. Because I can see, especially that last frame there, that rolling medially that you're talking about.
Yeah.
So, I would suspect something in the foot, but probably I would be more suspicious of the foot itself than the ankle.
Yeah.
Yeah, right there you can see it start to go in.
Mm-hmm. So it's just a matter of, okay, there's just a load, and as she gets into kind of mid-acceptance load, the whole thing is.
Yeah, and you can see it in her knee right there when at that point where it's twisted inward.
So Eric, you're thinking that maybe the lack of the hip extension is coming from something not occurring properly in the foot at terminal stance for that?
I don't even think she's necessarily lacking that much hip extension. I think her hip extension is pretty reasonable on that right side. I think that change, so this is more of that frontal plane change in the position of the knee, is probably more related to something going on in the foot than it is something primary at the hip.
Okay.
Because I think she has adequate hip extension. That's my reasoning for saying that.
Okay.
She definitely gets a little drop on the right side in the pelvis. You can see it right there.
I think in mid-stance, she actually has better control on the right of her contralateral pelvis. So when she's left mid-stance, her right pelvis drops more.
Yeah.
Yes. Yeah. It does. You look at that.
But her knee alignment is better. In left
knee alignment's better. She gets more pelvic drop, so she's probably transferring load better with maybe a better ground reaction force. Now, when she lands over here, it gets dissipated by the rotary moment. So she decrease drop here because see how the leg here is rotated? The ground reaction force may not be driving up to create a pelvic drop on the left. The rotary moment substitutes. So if you have equal and opposite force in each foot, the left side transferring a load better would probably contribute to the pelvic drop, where because we're getting that rotary moment, that leaking of energy in the right leg, the pelvis isn't going to drop as much. You get more of a kind of a pelvic rotation, femur spinning on pelvis, versus when she lands on her left leg, the ground reaction force drops the pelvis.
Yeah, and if we're looking at it from where she, like Dave's saying, leaking energy here, if she's leaking it out of the foot, right? So we would suspect some of those elastic elements, some of the joint capsules, some of the ligamentous structures, either in the foot or in the rear foot, midfoot or rear foot, is probably where she's failing here. So she's probably engaging her hip musculature much more to add that energy back into the system. And that's what's preventing that hip drop when she's on her right side. She's forced to use those gluteal muscles much more on the right because she's not getting enough of that passive energy generation out of the foot.
A question. I don't know if this is a dumb question or not, but here we go. Wondering why that makes sense. That makes sense to me, but I just want to play the other side. Like, why couldn't we? What could there be going on contractile in below the knee that would account for what we're seeing here at the hip? Does that make sense?
On the right side, you mean?
Yeah. So we're thinking like, okay, maybe there's a leakage of energy, the passive tension and, the joints of the foot not really doing what they're supposed to do, but what could be going on contractile that could account for what we're seeing in the hip?
If we're seeing rotary at the knee, then you got to, at that point, you're back to that unrestrained femoral internal rotation model. Maybe not the subluxation, but, you got to have, gluteal muscles, your glute med, posterior fibers, glute med, external rotators, those muscles, absorbing and kind of holding the hip in position so it doesn't rapidly internally rotate when you load. So it's the firing sequence of the force production of those muscles will limit the knee rotation. Now the quadriceps, you know, it has an active role in this in the loading phase, but it really is probably not going to do as much with rotation. So there's some people say, again, it will control some of the tibial rotation is controlled by some of the quad. But for that knee to drop in like that, it's got to come probably from the ankle or the hip.
So, right. So my question is, well, what could be going on at the foot that, you know, contractile wise that would account for what we're seeing at the hip?
Are you talking about from a deficit
Yes.
perspective?
Yes.
Well, there's a handful of things. I mean, the most obvious one to me would probably be some sort of loss in the peroneals. So when she needs to load that first ray and she needs to get that first ray set, right? So we need that first ray to drop toward the ground in order to set and become rigid. If she's not getting good recruitment out of the peroneals to do that, proteus longus to do that sort of thing, where it kind of pulls that first metatarsal down toward the ground. If she's not getting anything out of that, or at least not enough out of that, then that would cause her just to drop onto an unstable, I wouldn't call it unstable, but it's not fixated properly, first metatarsal, and that would cause that roll into the foot. So from a contractile perspective, if you have a deficit there, I mean, the other possibility is that she has some sort of deficit of the calf musculature itself, right? So we were talking last week about what's kind of driving us forward and upward. So the gastroc tends to be more of that forward propulsion, but the soleus tends to be more of that vertical lift to maintain that sort of stuff. So, I mean, any sort of deficit there would probably do it as well. But I would suspect we would notice a lot more as far as how she's having to use more hip flexor to get that leg forward. So it almost looked like she's flinging her leg forward on that right side, if that was the case. So, you know, again, I would go back to that peroneal stuff. Not anything can cause that, you know, any kind of problems there. Subluxation in the foot, subluxation in the rear, the heel, the ankle, fibular head, unstable mortise. I mean, even some sort of radiculopathy affecting L5S1 would also cause that sort of deficit. So there's all kinds of things there.
What about like poor activation of posterior tib? Because won't that also stabilize the arch?
Yeah, they kind of work together technically. Right, so one comes from the middle side and comes underneath, and the other comes from the outside. And so when they contract there, they're both supposed to help do that sort of thing. Posterior tib, though, there's only a couple of things that it doesn't attach to in the bottom of the foot. From a insertional standpoint. So I would suspect if that were the case, a deficit in posterior tib, you'd probably be having, you know, foot pain, actual foot pain. I guess I missed what she's actually coming in for. What is her complaint?
Well, I haven't disclosed it yet. So if everyone's ready, she does have plantar foot pain.
Yeah. Well, so maybe she does have
right at the yeah.
Where's her foot pain?
Right off the medial calcaneal tubercle and like quadratus plantae, like that, right in that area.
Okay.
So it's on the inside of the heel, essentially.
Yeah, right calf is very tight. She has a history of right hip pain with basically like almost like TFL tendinopathy that she has had PT for. I did not treat her for it. So that was at a different facility, I think, before she moved downtown. She's like 75% better, but she really wants to run more. And right now she's only running 2 miles at a time. And it's hard, like she'll do really well for a couple of days after treatment. And her joints don't seem that bad. like that stiff. I think her navicular on the right might be dropped a little bit. But other than that, there's nothing glaring wrong from like a joint mechanic perspective at her foot. Which is why we threw her on the treadmill on Monday.
So what do you think in what we saw in the gait, what could potentially contribute to that? We kind of covered things in both feet. And if you said she had plantar fasciitis, you could have said either foot with that, and I could have made an argument for why you get plantar fasciitis. If she's loading more efficiently through the left leg, it could be the drive leg. I mean, the right leg, what do you see in the right leg that would contribute to the plantar fasciitis? That's
well, like the constant dropping of her arch in, or that like rapid internal rotation is just going to constantly stress it. We've been heavily working on glute med. I think she'd probably benefit from revisiting external rotator work more. She's not weak, so I think it's more of a sequencing problem. I haven't found also any glaring hip mobility restrictions either, which I think we kind of discussed. It's not really like a hip mobility problem. I think she might actually be more likely to have like an L5 facilitation, of her left L4-5 or 5-1 aren't extending on the left. I think that's because I think she is more limited in left trunk rotation. So I think working on her external rotation strength and then sequencing so that as soon as she loads, she can activate those to decrease that arch collapse.
Are you doing intrinsic footwork?
Yes. Like arch doming?
Yes.
Yes.
And then that can progress. Usually I'll do is I'll progress that with single leg programming, being overhead pressing to, crossing patterns with one arm or the other arm, just because crossing patterns, the arm create rotary control with the foot. I'll make sure she can foot dome, she can control those.
Yeah, we're doing like med ball chops on the Dynadisc.
Okay.
With the spiky side up and single leg on the balance board, the circular balance board. So, all degrees of freedom, and a ton of like 3-way tippy birds to get that rotational moment too. She's still though, she gets a lot more long toe flexor activation rather than the real doming. I really find it difficult for patients to actually truly get the doming aspect of intrinsic footwork. So if anyone has any really good cues for that, because I find that it usually takes people a long time. As soon as they get it, they get it. But, I usually spend a lot of time on it.
It's the toe spreading. Often even just get them to track their knee between the second and third toes to make sure that the kneecap goes there. Sometimes that'll automatically get them to either rotate from the hip or fire the intrinsics to center the knee that way. Sometimes it could be an external cue of, okay, let me look at it from above down below. So have your knee track when you're squatting or moving between the second and third toe. And for that, they can't let the arch collapse. And if that combined, they can control it from the hip. You can also have to control it from the foot. So it's how do I use that external cue?
Okay.
If I could ask, doming, I've never heard of doming, but just want to make sure I'm with you. What does that look like?
It's firing the intrinsic muscles of the foot. And the arch doming is where you create a small dome, but you have to keep your body weight balanced between your first metatarsal head and the fifth metatarsal head and the heel. In yoga, they'll call it 4-point stance. So if you look across, like Tai Chi has a term for it, and even Pilates will talk about it. If you're in CrossFit, they'll use the term screwing your foot into the ground. And it's essentially the same thing of creating arch stiffness so you can transfer load.
Okay.
Okay, there's a nice free article in the British Journal of Sports Medicine on this, where Irene Davis goes over the foot core. I have it in my file. I can send it out. She'll go over this concept in running, and that's kind of the key concept. Is you want to build the foot strength up, just like you build the abdominal muscles, transverse abdominis, and core, so that you can absorb load in the foot and transfer load better. So it's really just working on that system of the foot intrinsic strength and endurance. Yeah. So that's kind of with her running style. The thing too, and Kara will be back in a second. She's probably just wiping sweat off talking to the patient. Tony, you doing foot intrinsic training?
I use the Dynadiscs a lot, especially when we're going to get to a weight bearing phase.
Do you cue for short foot?
I'm sorry, what was that?
Do you cue at all for short foot or doming?
No, not as much as I probably should. Only because I haven't really gone over the training for it specifically. So I almost try and like with the Dynadisc stuff, I'm almost trying to get it more like automatically versus more intrinsic thought process to it. But I'm actually looking it up a little bit more right now as we speak, just because I do want to make sure that if I need to cue for it, I can. Yeah.
You know, it's the same thing if you look at Yanda and what he talked about, basically setting the foot. His stuff matches that as well. It kind of overlaps with, you know, surely Salmon have a little bit in there with it. But the Irene Davis article is only just comes to mind just because I looked at it just again this past week, 2 weeks ago. That's on the British Journal of Sports Medicine. She also has a podcast on it as well. If you're a podcast.
Irene Davis?
Yes.
Okay.
But she's big on foot strength. She's out of Harvard. And she runs their running clinic, and she converts everyone into a 4-foot runner. And I'm not as cleanly putting everyone to a 4-foot runner because it's not quite that easy. But that's part of the hallmark of her retraining with injuries is, okay, let me move you mid-foot, 4-foot. But the foot core is kind of the main concept of you need this intrinsic foot strength to do it. Because where Kara running the problems with her is that she'll do well when she's doing a shorter distance run, but she's probably fatiguing out, and then that over rotation is probably going to stress her foot. So what she should probably be doing in clinic is run training in clinic. And, you know, you do that with either a metronome. You know, visual feedback's great, but it's hard to do with a camera. But that's really kind of the new standard in retraining is using visual feedback or auditory feedback for striking, like getting that left foot on and off the ground, that right foot on and off the ground faster at a tempo so that she doesn't have as much time to collapse. And they find that with the hip rotation decreases because of you have less time for it, then you have to get in and out of your strike faster. You have better force output, and it works better. And that's what they saw with hip strengthening programs, is that hip strengthening programs, though they improved the hip strength, they didn't improve the force output when you needed it. So that you still have this internal rotation moment, even after doing a 6-week single leg strengthening program. So you need to retrain the run mechanic. Which runners like to do in clinic. So it's good because they won't mind coming in to do a run workout.
Yeah, one other thing I noticed for her, which I think was harder, because it was harder probably for everyone to see from the videos today because we didn't really let them play at full speed, but she really slaps loud and hard on her initial contact, more on the right. Her cadence was around 171, and well, it was actually higher, I think, on the treadmill than it typically is, but she said when she tracks it, it's around 171 or 172. So we talked about trying to shorten her stride length and gently increasing her cadence so that she strikes a little bit further underneath her. And if she does that initial contact on the right, more underneath her center of mass, won't that also facilitate less of a load and probably less of that like rapid internal rotation?
It does, and probably because it all has to happen much faster. You know, you don't have this lag time of being able to load through your foot passively. And it's being more of a passive system. As she loads more rapidly, again, the force output in the muscles has to be greater because she has to load it quickly with intent. Because there's that almost, in lots of running, there's that loss of intent. It becomes a very passive activity. So what she needs to do is have it being a little bit more purposeful, and especially on the right-hand side where it's collapsing a bit more. She's getting the rotary force. So it's finding a way to control the rotary force. Now, the strengthening component of it, you don't ignore. you still do it, but that's a piece of the pie, but it's an equal piece of the pie, probably to the run retraining. And it could also be too, is like the thought process too there, if you look at right and left extension, is that right extension almost a little bit more passive than the left extension? Because she's not storing energy, she's not coming off the foot as fast. So you see, seems like she extended more on the right than the left. But is that foot just kind of riding out on the treadmill? Is she not driving off of that leg with a little bit more intent than the left leg? So her recovery won't be as fast, and it'll change the gait cycle too. So sometimes it's getting a sense of getting that foot off the ground a bit faster with intent to speed up her cadence. And that idea of trying to speed up the footwork on that right side can decrease some of the rotary moment in that right leg, especially if she's only running at a 162 or 172.
Yeah, well, that's what she said she regularly clocks herself at. Yeah. And when I did like a 30-second count here, she was right around 180. But I think she actually said, I think that's not what I normally do. It's probably just because I was on a treadmill.
Yeah. And otherwise, you also see too in common female runner, if she's getting an anterior hip pain or some TFL, that large extended position, if she lingers in this extended position for very long, it can put a lot of torque on the anterior hip. So it could be, you break down the capsule a little bit or the labrum. So you'll see a lot of like this type of runner who lingers too long in late stance. It doesn't actively kind of store that energy and get out of it faster. It tends to create some irritation in that anterior hip. So she may have some TFL issues, but I'd guess because of her hip and lumbar position here that she's probably torquing through the anterior hip if she was marathon training. So shortening up the gait cycle and getting the foot off the ground a little bit faster with intent tends to not lever through the anterior hip.
Cool. Thanks. I think that's going to be helpful.
I'm trying to think of the running reference for gait cycle. Irene Davis, she has a couple studies done where they looked at it was video they generally used and auditory input. Both seem to work pretty well with run retraining. So I would definitely
for cadence.
Yeah, for cadence. And just trying to speed it up a little bit and see, can she do that? And does that minimize the rotation?
Yeah, I recommended for her next couple runs to metronome set at like 174, 175, or anywhere up to 4 beats higher. Turn it on for a minute, off for a few minutes, on for a minute, off for a few minutes, and see how that goes. And then after a few runs there, try to bump it up to like 178 and see.
Yeah. I also do too sometimes, because that can be hard to track, is I'll have them put the metronome, like instead of 180, I'll have them put the metronome at 90 and then track right foot. So it's easier to track 90 beats than it is 170, because it just happens so fast it can get kind of blurry. So I'll work on one leg tracking, and I may switch right and left legs depending on, okay, I get off cadence a bit, but I'll go 90 and then just think of that right foot. What is my right foot doing? I'm getting it on the ground, I'm getting it off the ground, I'm doing it efficiently. So that'll give her a little bit more focus. Any other thoughts on retraining, Eric?
No, I mean, you guys have kind of gone over most of the stuff that I would have considered at that point.
Yeah, the other thing too is you have your clinic, and then I generally don't run them out straight. What I have them do is basically I'll do running intervals just to spread it out, just for tissue load. That way, okay, I see that she can control it, because she's probably able to control it for a shorter period of time. And then, she'll maybe lose it a bit if she's running for 2 miles. So just having her do interval training so that she could, that she can better control the foot. Plus she get rest, so the tissue load isn't as great.
So like half mile, quarter miles?
Yeah, half mile, quarter mile,
okay.
Go a minute, 2 minutes. Just see where she can control it, with the metronome, then pause a little bit and break. That way too, it's like she can almost, she'll feel like she's getting a training session in, like you do it at the back end of a session or somewhere where it fits, so it can dovetail with your next patient. That way you can just kind of keep an eye on her. You get your next patient going. she feels like she's got a workout in, while you worked on these elements.
Yeah, I wondered. Oh, sorry, go ahead.
No, they often recommend 12 sessions or, quite a few sessions to really get the retraining down pat.
Yeah, I wonder what it would look like for her. This was actually, I taped her after she had already run 2 miles also. And I wonder what it would look like for her not fatigued and at a faster speed, or if she had at a faster speed, would she have better control and less of that rapid internal rotation? I get more knee pain when I run slow than when I run fast.
Yes, it tends to improve as you run faster. If you see the treadmill up, everything that tends to go away a bit more, as well as the pelvic drop.
Unless she is dealing with a facilitation.
Ooh, good point.
Because the facilitation will show up with speed.
I didn't think about that, but that is absolutely true.
So that's actually not a bad call, Kara. Try and speed her up, because that could give you your answer.
It would be more obvious. The problem would be more obvious if it was stemming from a facilitation.
Yeah, the velocity dependence of the facilitation should become more pronounced at a higher speed.
I think she'll also be happy to run faster or intervals, because I think she's in law school and is working, and I think running is her like mental release, and because she doesn't have that, I think she's really struggling, especially like pandemic and home and in a 1-bedroom apartment with her husband. And
the thing that can ameliorate too is, I don't know if she would do it with her running just yet, but she's not anything special. Teaching her to low dilatate her foot. She's getting symptoms walking around in law school.
She does law school from her bedroom.
Oh, jeez. Wow.
Or like home, she's home doing school. And so she's just sitting a ton. And, on Monday morning, it was beautiful. And she's like, if I didn't have foot pain, I would have run 10 miles today, Okay, I got to get this. I'm going to mute myself.
There, if I go to left
the
leg
facilitated segment be the bigger cause of her foot pain?
Absolutely.
Yeah.
Because if you think about it, what we have that kind of that point pain on that medial calcaneal tubercle, a lot of times you'll see that when somebody is not getting good arch support out of the posterior tib and out of the peroneals, right? And so they're coming down, and those things they're either given out because of the speed of the contraction necessary to hit there, and they're ending up dropping onto those intrinsics, right? And so you'll get that kind of almost like an insertional tendonitis from some of those intrinsics attaching to that medial calcaneal tubercle.
Right.
The other option, Dave mentioned it before, but is she's actually landing on that tubercle, right? And so that would create more of an impact issue. But typically you're more likely to see that with a EUFER than you would with a true foot problem.
Right.
Because that's going to allow the foot to more internally rotate during heel strike, right? And so she's going to end up striking that medial edge of the heel instead of the lateral edge of the calcaneus, where it's much more padded and much more tolerable to that sort of thing.
Right.
Or the hip rotation in, like her center of mass line, which should be going, basically heel, then wrapping around the lateral part of the foot, basically more the lateral arch, and coming up at the level of the second or third toe, and then goes medial between the fourth and fifth toe. Like, because she collapses rapidly, the center of mass moves more through the medial foot, so it'll stress the plantar fascia, because her center of mass in mid stance is probably more to the middle arch than the lateral arch. So that line comes up about the level of the second toe. So it's more of a straight line through the foot. I'll see if I can pull one up.
Yeah, I was going to say, you can probably see it. Because her medial calcaneal tubercle looks like it's right underneath her, the line of her spine there.
Let's go through some slides. Okay. Do a new share here. Okay. Can you see the gait scan or gait scan timing and report?
Yep.
Okay. So this will show you basically striking pattern of somebody's foot. And you'll see here that the colors correspond. So blue is lateral heel, I don't know what I'm going to call that one. I'm going to call it pink for lack of a better color wheel, is the other part of the heel. That's your vertical ground reaction force. The line you see going through the foot, that's your center of mass. That's where your center of mass is kind of traveling over the foot. So you probably can't see my pointer here, but that should be going more lateral. See how that line in this foot goes medial right up between the second toe? That line should be coming up more about where the third toe is. So if I draw a point from the heel to the shadow of the third, 1, 2, 3, third or fourth toe, it should be coming up over there, then coming medial. So this is somebody who's gonna collapse their center of mass through the medial arch, much kind of like what I would project that she would do. So what you see here, this person actually has a high arch, so they don't actually bear weight through the arch because the green line would be the foot, and as you can see, that's the smallest line on the gait scan. And she basically goes, this is a heavy heel loader, which then transfers load right to the metatarsals. In this case, the fourth and fifth metatarsal are the bigger lines there. So there's some in the third, but mostly the fourth and fifth. It just gives you an idea what the gait scan, is, and just the vertical ground reaction force here is a big driver of pain that they see in people. But this person's a heavy heel striker, heavy heel load, very little transfer through the midfoot, believe it or not, though the center of mass moves through it. And then you can see as I start to unload my heel, I transfer that load right to the forefoot. But really that line through the foot is that center of mass I talk about, where her line is going to be moving medial. But you can see I was going to stress the plantar fascia and medial arch because she's not using the articular system and the stability of that system to bear the weight.
Did I miss anything about facilitation?
No, I was just asking if it was a likely larger driver to the foot pain, and they were in agreement on that for the most part.
I think what Eric said, it's not the primary driver. The facilitation isn't causing the pain. It's causing the muscular weakness.
Right.
Lead to that collapse, that everything you might see in that gait scan where you're bearing weight more. The center of mass moves more through the middle of the foot, which would then stress the plantar fascia. And the posterior tib or peroneals being inhibited would then destabilize the arch.
Yeah, you'd be way more likely to have, lateral hip pain, some shin splints, stuff, hamstring pain, stuff like that, if the facilitation was the primary driver from a, muscular perspective. Mm-hmm. Those are going to be way higher on the list as far as actually being the areas of pain than the calcaneal tubercle.
So if we had her do intervals and speed up her speed and that cadence, is that something that we would likely see an immediate reduction in her plantar foot symptoms if it was not facilitated by facilitation?
Whoa. If it was not facilitated?
If it's not facilitated, she would feel better when she runs faster because she has more muscle activation. Is that something? The question is, would she feel immediately with running less pain? Or is that some, you know what I mean? Like how fast is the feedback? So now we have like a new test to do, put her on a treadmill or have her run faster. How are we going to know it works?
Here's the problem that I would have with saying she'd have immediate relief is that there's likely some tissue damage in the foot, right? So just loading that tissue is probably still going to be uncomfortable, even if you solve the solution, like, well, her cadence or the speeding her up is the solution. The odds of it just being gone with that aren't real great because the foot itself is actually still painful, right? So just loading that tissue, even with normal loads, more appropriate mechanics, you're still going to get load on that tissue. So it's still likely to be painful at that point, would be my suspicion.
Mm-hmm.
it would be less likely to be overstressed. And so it would still be able to go through the healing process as opposed to kind of, recurring into these dysfunctional states. So that would be one of those things where, you're talking to a patient and they're asking you, when can I go back to running? And, a lot of therapists will just go like, well, as soon as it's pain-free with, walking and daily activity, now you can go back and try that sort of thing. That's not always the case, because you can, once you get into the situation where you've unloaded, you've removed the excessive load, right? So I want to make sure I'm stressing that. Once you've removed that excessive load, the tissue can continue to heal. And then you can tell the patient like, well, you can go run on this, but it may still be uncomfortable to do it. You're not going to do any more damage to it at that point, if that makes sense.
Yeah, so then for a couple of weeks, should we almost like only do shorter, more interval, higher speed activity and see how she does?
I would think so.
I think it'd be more reasonable, because as she fatigues, this will get worse, and its dosage, she'll overload it. So being able to control the amount of dosage, you can run faster. I usually don't recommend I will often have people try and work on cadence before I even have them run faster, because if I pick up her cadence, it'll fix it. Like if you try and have her run faster with the same mechanic, you might just accelerate all the forces. Because now all of a sudden she's got unstable foot hip mechanic, and now it's happening more rapidly. It may accelerate the stress on the system. So part of it is okay, can I get her to have clean footwork? Can I clean up some of that internal rotation moment that's occurring first? And then you can do that with either, I may work cadence. Sometimes I work cadence at different speeds, teach them to run. Can you run 180 steps per minute at the slower speed? And then can you do it 1.5 miles an hour faster? So it may be doing it. I can do it at a 8:30 at 180 steps per minute, but then I can also do it at a 6:30. And my cadence stayed the same. So it's getting a sense of, can I change that barometer? Because it'll be stressful for her to do it. She'll feel like she's getting a hard workout, because she is, until she gets more efficient at it, and she'll develop efficiency. So I necessarily may not say run faster with the same mechanic. I would say let's work on the speed and cadence, clean up that problem, and then do it at various speeds.
Well, and that's part of the other issue that she might present is she's a heel striker, right? So a lot of times you start speeding heel strikers up and they start forefoot striking or midfoot striking. Yeah. Mm-hmm. So just because the increase in speed, that impact on the heel becomes a little more jarring, and so they'll end up trying to soften it, and so they'll put their toe down instead, and now all of a sudden the whole mechanics are completely different. Yeah. And in her case, if it is an issue with she's not transferring load from the heel strike onto the medial foot appropriately, and that's what's kind of getting at her, switching her to a more of a forefoot strike might actually help her, because you're taking that phase out of the equation. Yep. So those are things that you can always consider. Now, making a drastic change like that on anybody's running style is always a huge undertaking for me. But I mean, that's a possibility where it's just like, well, you know what, if your problem here is transitioning from the rear foot to the forefoot, take the rear foot out of it.
Yeah, especially because her left side, she is not as strong of a heel striker on. Mm-hmm. So it's I wonder which one is her default and which one is compensatory. I don't know, because we'll never know, but I think if we work on those things, I think she might end up striking a little bit more midfoot anyway, and we'll see what happens.
Yeah, and you never know. I mean, that could be all it takes, but
yeah,
she's still got something going on, right? I mean, there's still something there that's changed, right? Because I'm guessing this isn't a new activity for her. Running isn't something she just picked up 6 months ago.
No, she's been running for a long time.
Yeah, so something changed. Something is different now than what it was before she started having this problem, right? So that's still something that's likely to give her issues somewhere. You know, I mean, whether that ends up being more of like a, you know, if it is an L5 facilitatory problem, she may end up with more of a hamstring issue, some sort of, you know, insertional hamstring problem, you know, or some sort of glute tendonitis, or, you know, trochanteric bursitis. Something will eventually break down with the problem that she's presenting with. So that's kind of the tough thing with saying like, oh, we'll just coach her into a different strike pattern. You know, you can, if it comes down to that, you can certainly do it, but it's a dangerous game, because you're just leaving her out there with some sort of either neurophysiological or biomechanical dysfunction that's eventually going to break something down.
Yeah.
You know, so I mean, but, you know, I tell patients this all the time, that I could bring in 100 people off the street and I would find something wrong with every single one of them. You know, whether it's some sort of facilitatory effect, whether it's some sort of biomechanical problem, some sort of joint restriction, whatever it is, every single person that I pass on the street has something wrong with them. Nobody is perfectly biomechanically or neurophysiologically. So, you know, everybody's compensating for something. It's just a matter of, is that compensation going to affect one of your kind of daily tasks, and especially a repetitive task like running or cycling or typing, you know, any of these sort of things that you do for prolonged periods, and it's kind of a cyclic motion.
Mm-hmm.
That stuff will break something down eventually. So anyway.
Cool. I'm excited. That was really helpful.
You had to be terrified when somebody came in with foot pain, I'm sure.
Huh?
You had to be terrified when somebody came in with foot pain, right?
Yeah, feet are so scary for me now.
Afraid you're going to have to treat the foot, treat the ankle.
I'm sure I've manipped her ankle before. Okay, I have another, hopefully short question if you guys have time.
Sure.
When I have another patient who is undergoing, I believe, left L5 nerve ablation.
Okay.
And she had her first treatment on Monday, and then she has a second and third subsequent ablations the next 2 Mondays, basically. So what exactly do they ablate the nerve root? It's not subdural, is it? Because that would be bad.
It's the medial branch.
Okay.
So they're looking, and I've had a patient that I've been dealing with for months that's had problems with his back, and hip and stuff, and he had a injection done, and the injection did great. He's like, I feel great. It was good for several months.
An epidural?
Yeah. And okay. So he had this done, and they immediately said, well, we're going to do this nerve ablation that are supplied by the medial branch of the multifidi in the facet joint.
Okay.
So they're hoping for a facet syndrome with the ablation. Mm-hmm. The problem is the sinovertebral nerve, the recurrent sinovertebral nerve, does the dura, does the posterior longitudinal ligament, the disc, the periosteum, ligamentum flavum, all these other structures that could just as easily be painful as the facet, right? So unless it's going to be the joint capsule or the joint itself, or potentially something with the multifidi that's right there, the ablations can be useless.
So why don't they ablate the sinovertebral nerve then? I mean, that seems like a pretty obvious thing. Just like do them both, right?
Look at me. I don't do them.
And what does this patient have pain with? Which motions create the most pain?
It was forward bending, rolling in bed.
It's got an SI joint problem.
All right.
Yeah. I mean, that
not a
too.
facet anyway.
Her lumbar spine is extremely stiff. She's 59. She's a D1 college or like lacrosse and I don't know, some other D1 sports. They were like national champions. She's super fit, can't ride a bike. Like even a divvy bike, which is like the big heavy city bikes for 2 miles, is like so painful for her. We saw her a little before the pandemic, and then she went to the Shirley Ryan Ability Lab, which is formerly RIC. I don't know if you guys know anything about that. Their doctors are like super into Mackenzie. So she saw a doctor there virtually and had virtual sessions and did Mackenzie and like didn't get any relief, obviously. And
they're taking her in her directional preference anyway. Because extension is better than flexion, right? And so they're just forcing her into extension.
Right.
Saying that's going to fix the problem.
Yeah.
Which was a facet joint, I would think it'd be more irritable driving it into an extension moment.
That absolutely would be.
Right.
Absolutely.
So, or if it's arthritic, right? Like facet, you know, any of that. And so on her first visit, I think we did a lot of stuff, but she also has very poor hip extension on that side. So I did the hip smack technique. She's super tight. She's always stuck in like an anterior tilt because her quads are really tight too.
On both sides or just the affected side?
Worse on the left. Her hip extension on the right was fine. So I think probably having poor hip extension has bothered her. She does really well with needling, so I've needled her glutes and her multifidi, even like scraped her lumbar fascia. She always feels so much better when she leaves, and then she thinks that this ablation is gonna like fix her, you know. So she's like, oh, I had 2 hours of complete relief. I'm like, well, that's because they just numb the shit out of you everywhere, right? Like it's I understand the initial numbing agent being somewhat diagnostic. So if they stick it in the right spot, they know they're in the right spot. But then it, you know, started to come back after 2 or 3 hours. And so they're going to do it again 2 more times.
So is her like, are her primary complaints the biking and the transitions?
Yeah, she used to have excruciating pain sitting and would sit to stand. Now she can sit for a couple hours. She can stand. She ran 4 miles last night.
The pain is just in the back, though. It's not leg pain.
Correct. And it's like between the SI joint and her lumbar spine. Or like between the SI joint and her spinous processes, basically L5 through S2.
Yeah. So I mean that's Fortin's point. So I mean,
yeah.
I mean, I would say that she's very unlikely to have a lot of relief with this ablation. Just I mean, for all the stuff that we've mentioned, I mean, number one, Dave's talking about you would be worse in an extension position, and I mean, I can't even imagine the situation where the flexion-based movement would actually irritate a facet more than any type of extension movement would. The location of it, as you know, is another thing. Basically, being there as opposed to, you know, on the spinal segment. The things that are irritating it, so bending forward and then and the rolling over in bed, those are almost pathognomic with sacroiliac dysfunction. The fact that it's so painful for her as well, or it has been so painful for her as well, would tend to suggest some sort of inflammation in the area, which is more likely with something like a sacroiliitis than it is to be a facet lesion in the spine.
The other one would be kind of Peter O'Sullivan's like flexion model or flexion driven model. And I pulled a picture up just from one of his old articles. And what you may find is to look for her is, do you see the L5-S1 segment flexed? It'll be rounded and kind of puffy, and that segment will be flexed. And again, see in this patient, he's got the lordotic segment above it. So the rectus spinae and the back muscles will be all hypertonic above it. That segment will be flexed. And what these people tend to do is they'll be in a posterior pelvic tilt. Okay, so when they flex from that unstable L5-S1 segment excessively. So if she goes to go forward, she almost can posterior pelvic tilt the pelvis, and she'll flex through that segment early and more aggressively. Instead of normal forward flexion should come from the hip first, and then blending in portions of the spine after. So sometimes in somebody who's her age group, get a sense, look at the L5S1 and see, okay, is it rounded or kyphotic? It'll be kyphotic in disc patients. You'll see it in chronic disc patients. Degenerative segments will be slightly kyphotic, but you'll get this lower lumbar kyphosis. They're usually more limited in extension because they're stuck in a bit of a kyphosis there. So they won't extend well through that segment, but you'll have similar pain like that. It'll usually be even on the initiation of flexion. So she's a cyclist. He wrote two case studies on it too. One was a rower where they were hinging too much through here. The other one was a cyclist where they looked at a bunch of cyclists with back pain, those without, and looked at these hinge angles in people and found that these cyclists were the ones that had more back pain. And they tend to be kyphotic here and getting more of that flexion moment from the lower back than from other segments. So it's also common in sitting because they'll sit in a posterior pelvic tilt and they'll overflex this L5S1 segment in the sitting position. And they have a hard time really disassociating back motion. So you start to play with them, they have a hard time getting a pelvic tilt and getting the back to basically the lower segment, the lower dose or change. So they get this dyssynergistic pattern. I'm gonna look at it. So, I don't know that she has this, but it's definitely worth mentioning. And it's not one that, I don't think they covered so much in the courses, but it's just a nice one to look at. He has flexion and extension patterns that he looks at. He used to have a lateral pattern, but I think he threw that one out. I can send you the old article. This is actually this is from a master class in manual therapy. The initial article was in manual therapy, but I have a bootleg copy of they put together a bunch of back articles, and Diane Lee's biomechanical article is in there as well, where she does that. So I'll send it over to you.
Hey, Dave, can you send it to me too? I got a patient.
No, Tony, I'm not going to send it to you. It's the first time you've been here in weeks. You're screwed. Yeah.
So I've mobed her for flexion, and she does really well.
Flexion mobbing that segment?
Yeah.
Yeah. So she may not have this at all, but it's just a cool thing to talk about at this point because you'll see. I have a guy right now who is exactly this, and he does exactly this pattern. He goes to flex, he posteriorly pelvic tilts, levers through this segment, and he has a terrible time trying to initiate flexion from the hip. He's totally dyssynergistic. He's lordotic in his upper lumbar spine. So he's essentially this pattern. So a lot of what we have to work on is rewiring this pattern in him. So he's nice because he matches his classic kind of Peter O'Sullivan model.
Mm-hmm.
But two good articles. One was JOSPT. I think the other was in manual therapy. The cyclist one, so I don't have a copy of that. I'll look for it. And the rower one was in JSPT maybe 3 or 4 years ago.
Cool. I've also looked at her. I mean, she's kind of stiff all the way up in her TL junction. And I've looked at her lower ribs because she says she's very in tune with her body. And she's like, if I just push really hard on her QL, it relieves her pain.
Yeah. Part of that model he talks about is the muscular tone and that muscular hypertonicity.
Yeah.
That'll wrap around this. And she's kind of in that model where you see this upper TL junction wind up because of the hyperlordotic posture up in there and how the curve changes. So you'll see hypertrophy, the erectors up there. The QL will be hypertonic. If she shifted, it could be hypertonic on the one side, not the other, and atrophied on the other, or the erectors could do the same. So it's an interesting model to look at. Just because it is a pattern that you'll see and like, oh, that's that pattern.
Yeah. Maybe I'll tell a doctor to ablate her synovial nerve.
Mm-hmm.
Just joking. I'm not going to do that. Okay, that was super great. Thank you.
No problem. That'd be a good one to follow up on next week.
Yeah, for sure. I'll see her 3 times before then. But they told me I can't really treat her back while she's undergoing all this ablation stuff. So
treat her posture.
Strengthening hip mobility. I've been working a lot on like getting her quads to calm down.
Mm-hmm.
Like, scraped her TFLs the other day and she felt like immediately better.
Mm-hmm.
So, I mean, I'm just teaching her a lot of stuff because she's actually going to be going away for about a month after this. So I think I get 1 or 2 shots at treating her back after the ablations. But
look at her flexion pattern. Make sure she's initiating from the hip. If she isn't, then work on flexion from the hip. Make sure she's not posterior pelvic tilting as part of her initial thing and flexing, trying to flex from that segment. It's the same thing she would do.
She literally never posterior pelvic tilts unless I make her do it.
Okay. And she may not be this pattern at all.
But I'll look at it because she might be, you know, the opposite cluster.
Yeah. I'll send the article to you. You tell Tony about it.
Yeah.
But I might have this case for next week if
Good.
it matches up. I got a complicated back patient right now, SI pain. He seems to match this kind of pattern, so it'll be interesting to see. I'll make sure I'm in next week when I'm here.
Yeah, because like I'll use this when I teach needling. You know, that's one of the cases I'll do. Is this pattern, because you'll see all this muscular wind up around it. It kind of ties in a few different themes. What we do manipulatively, what you're going to do. What he has myofascially in there, and then biomechanically, how do I correct? All right. I'll catch up with you guys next week. Send me if you have any questions, just send me over. I'll kick the article over probably tonight.
Okay. Thanks, everybody.
Thanks, guys.
Bye.